Hi, my name is Alan Kinlaw. I'm an assistant professor in our School of Pharmacy's Division of Pharmaceutical Outcomes and Policy. I'm looking forward to meeting you in class later this week and working with you the rest of this semester. As we shift gears in this course toward the unit on study design, I'll be talking to you about causality and bias in clinical research. To give you a sense of where we're headed in this study design unit, you'll learn today about foundations of causal inference and identifying sources of bias, which will be useful to guide you as you read and scrutinize published studies to guide your clinical understanding and practice. In the next few sessions, you'll learn about different types of study designs, both experimental and observational, that can be used to address questions in health research and the relative benefits and drawbacks of each. This slide is a reference that might be handy as you listen or review this lecture or read studies. Some of these words are used interchangeably in our field, but not always explained so clearly. I call special attention to the thinking emoji at the bottom. Not an epidemiology term, of course, but I place it on slides in this class to let you know that it refers to the information that might be an oversimplification. Our mandate in this class is not only to teach you valid scientific information, but it's also to help train you for the culture that you'll be working in one day. Today's learning objectives are these. First, to imprint your mind on causal thinking through counterfactuals and the potential outcomes framework. And then second, we'll discuss complementary ways to assess evidence of causal associations. In the second big chunk, we'll transition to understanding bias. We'll define the big three and learn how to describe the direction of bias. Finally, we'll wrap with one of those cultural lessons, the so-called hierarchy of study designs. As a note for today's lecture, we'll have a clinical example that gets brought up at several points. This is based on student feedback that it would be helpful for a consistent example that has real-world implications. I've adapted this example from a study that I conducted a couple of years ago. So here's our PICO. We're interested in a population of patients who are Medicare beneficiaries seeking treatment for diverticulitis in the outpatient setting. The intervention and comparator are treatment with metronidazole and fluoroquinolone. I'll call this ciproflagyl for short, or amoxicillin with clavulanic acid. I'll call this amoxclav. The outcome is C. diff infection, which is a serious adverse outcome associated with certain types of antibiotic therapy. So as we get into this lecture, you might be thinking, why should I care about causality theory? The number one goal that you have as clinicians, in your case, and in my case as a researcher, is that we want to improve patients' life experiences. Whether we know it or not, we use causal inference and thinking to balance expected benefits against expected risks of medications that we consider for our patients. Having a clear framework for causal inference makes it easy for you to distill information that you read in trials and observational studies, understand the assumptions inherent to those studies, their strengths and limitations, and their relevance to your clinical practice. We're going to start out with a fun little example of how to tell a causal association from a spurious one. Here's the setup, which is rooted in the fact that I love soccer. I love playing and coaching it, so I promised my friends on my soccer team that I would score more goals this year. I'm only so good at soccer, and it's too late to improve my skills very much, but I have a hunch that if I pick the right jersey number, it might help me score a lot. To investigate this question, I found data from the top 125 goal scorers in last season's English Premier League. I wanted to find out what jersey numbers would give me the best chance to score a lot of goals. Plotted here is the number of goals on the y-axis and the player's jersey numbers on the x-axis. Each dot represents an individual player. There's a couple of superstars, Son and Salah, who scored 23 goals each. Another superstar, Harry Kane, who got 17. And then some of my favorite players who had considerably fewer goals than that. When trying to make some generalizations about the data, here's what sticks out to me. I definitely should not pick number 1, 12, 13, or most of the ones over 30. And there are two ranges that look pretty solid, 7 through 11 and 17 through 20. There's no way that this is going to help me score a bunch of goals, but the data definitely do show an association. Focusing on jersey numbers obscures the fact that there are real reasons why players with these numbers score a lot of goals. As you can see on the right, numbers 7 through 11 tend to be worn by players who play on offense, so naturally you'd expect them to score more goals than other players. On the bottom left of this slide, you'll see potentially the first directed acyclic graph that you've ever looked at. We'll dig into these diagrams more later today and in future sessions. What they do is help us formalize the associations between variables that are important to our study question. If we're interested in whether or not jersey number causes goal scoring, we can factor in two big issues. First, that traditionally numbers are associated with the position that someone plays on the field, as you can see on the right. Second, the combination of talent, speed, seniority, and poise that helps a coach choose what position to put a player in, and also impacts how good that player might be at scoring. When we think about those factors, they're the ones that are driving the association between jersey number and the number of goals scored. So, okay, this soccer jersey example illustrated a non-causal or a spurious association. But what makes an association causal? Generally speaking, if outcome occurrence differs between two groups and all other characteristics are equivalent except for exposure, then the exposure is causally associated with the outcome. To keep discussion simple, we're going to move forward with exposure being a dichotomous variable, like one drug versus another, that are tied to realistic interventions. This makes sense for your real-world practice because you often will find yourself considering a couple of options and the ability to intervene on a patient with one of those options. There are three technical essentials for an association to be causal. They're consistency, positivity, and exchangeability. Applying these rules to our diverticulitis example, consistency means that when we make a prescription for one of these medications, we expect it to be filled and consumed as directed. Positivity means that all of these diverticulitis patients could reasonably be treated with either ciproflagyl or amoxiclav. And exchangeability means that both antibiotic groups had similar degrees of all the other characteristics, like severity of diverticulitis, healthcare use, age, that might inform the prescription decision and might be associated with underlying risk of C. diff. In our published study that I talked about earlier, we found evidence suggesting that outpatient use of ciproflagyl compared to amoxiclav may cause higher risk of C. diff infection in Medicare beneficiaries with diverticulitis. So we interpret this as a potentially causal association, but with appropriate caution. Some reasonable arguments against this being a causal association are that outpatient prescription fills are imperfect proxies for medication prescribing, the consistency rule. And there might be some unmeasured systemic reasons why some patients received ciproflagyl while others received amoxiclav. I also show some examples of what would not be reasonable arguments against this being a causal association. These are the kinds that you should stay away from. First is that, well, this is an observational study. It wasn't a randomized trial. We'll get into reasons next session about why a trial would not work for this question. These last two bullet points illustrate a really important take-home point around causal associations. Causal associations do not need to be what we call deterministic. Someone might look at this and say, erroneously, that C. diff infection can't be caused by ciproflagyl because tons of ciproflagyl patients didn't get C. diff. Or alternatively, some amoxiclav patients experience C. diff. Not all smokers die from lung cancer, and not all lung cancer is caused by smoking. A causal association is not an always or never thing. It's often probabilistic. Counterfactual theory is the best way to identify causal associations. A general example of this thinking goes like this. If you think that an exposure is causally associated with an outcome, then you might want to know what would happen if the people I saw get exposed had instead, and counter to the facts, not been exposed. Would their outcome occurrence have been different? What if I could give them an alternative exposure? What if, instead of showing up to my soccer game right before kickoff last year, I had gotten there in time to do a good warm-up? Would I have sprained my ankle in minute 3? In our diverticulitis example, let's say we think that ciproflagyl is associated with higher risk of C. diff. Our counterfactual question would be, what if the patients who got ciproflagyl had instead, in counter to what we saw, gotten amoxiclav instead? Would their risk of C. diff infection have been different? You might be thinking, this is crazy. You can't go back in time and toggle people to a different exposure. And you're exactly right. You can only do that in the movies. But to apply counterfactual theory, if circumstances are right, we can find substitute populations who can stand in as equivalent counterparts in a competing exposure group. We can think of them as stand-ins because other than the exposure, they have really similar characteristics to the people who got exposed. If the substitute population breaks any of the 3 essential rules for causal inference, then that inference is limited. But sometimes it's easy to get bogged down in the weeds and technical details. It's good to be aware of these technical details, but when in doubt, your golden question for reading studies and thinking about causality is kind of simple. Is this a fair comparison between these two exposure groups? This is a good place to take stock of where you're headed in your clinical training. Compared to someone like me, who works with clinicians really closely, your clinical training is going to give you a ton of specialized knowledge and baked-in intuition, which will help you interpret and scrutinize published evidence. Now that we've finished the first chunk of this session, we'll take a short break. This might be a nice time if you want to pause this video before moving on. On this theme of fair comparisons, we're now going to turn to an early historical example of people navigating toward counterfactual thinking. You'll get to play the game that these people played, and it should be really clarifying for how some of these causal theories fall into place. So what we're going to watch right now is a short video from one of my favorite TV shows on PBS called Nova, where they have a really great example of this thinking.
The gambling observations that led to the law of large numbers were a start. But what really launched probability theory and opened up a door to a whole new way of thinking about the future was a series of letters exchanged between two French mathematicians, Blaise Pascal and Pierre de Fermat, in the 1650s, about another gambling problem that had been kicking around for a few centuries. A simplified version of the problem goes like this. Two players, let's call them Blaise and Pierre, are flipping a coin. Blaise has chosen heads and Pierre tails. The game is the best of 5 flips, and each has put money into the pot. They flip the coin 3 times, and Blaise is ahead 2-1. But then the game is interrupted. What is the fair way to split the pot?
The question is, how do they divide up the pots so that it's fair to what might have happened if they'd been able to complete the game?
Fermat suggested imagining the possible future outcomes if the game had continued. There are just 2 more coin flips, creating 4 possible combinations: heads, 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 tails, tails, heads, and tails, tails. In the first 3, Blaise wins with enough heads. Pierre only wins in the last case. So Fermat suggested that a 3-to-1 split was the correct solution. The key breakthrough was imagining the future mathematically, something even Pascal had trouble with.
Because what Fermat did was say, let's look into the future, look at possible futures, and we'll count the way things could have happened in different possible futures. It was a simple arithmetic issue, but the idea of counting things in the future was just completely new, and Pascal couldn't wrap his mind around it.
Eventually, Pascal accepted Fermat's solution, as did others. And today, that exchange of letters is regarded as the birth of modern probability theory.
People realized the future wasn't blank. You didn't know exactly what was going to happen, but you could calculate with great precision what the likelihood of things happening were.
So in the video, you saw that Pierre and Blaise didn't have data, but they were able to project future possibilities of the scenario that they found themselves in. They had information about what could happen in the future, but not necessarily knowledge of what will happen in the future. They flipped enough unweighted coins in their life to know how that would shake out if they were able to do it. But now we're going to transform this example into an application of potential outcomes thinking. Blaise and Pierre knew that an evenly weighted coin is going to turn up half heads and half tails over time. There are 2 more coin flips that they had left to do. After the coin flips are carried out, we'll only get to observe one value of Blaise's potential outcome. We know that the probability of him winning the pot is 75%, but we only actually get to see him either win or lose the whole pot. Let's shift this example toward a setting where Blaise is our patient with diverticulitis. Please note going forward that all the data in this example about Blaise are completely made up for teaching purposes. So in Blaise's patient history, during time periods 1 through 3, we imagine that there's this clinician who's observing Blaise's health status. And she's weighing whether or not she should treat his diverticulitis with ciproflagyl or a amoxiclav. After time point 3, it's time for her to make her decision. She opts for the more standard treatment, ciproflagyl. At each time point, 4 and 5, under treatment with ciproflagyl, the probability of having a good health status, is a blue circle, is 50%. After time 5, we'll be able to observe the value of Blaise's potential outcome. Either he'll be infection-free, at least 3 blue circles, or he'll be infected, less than 3 blues. We see that both circles will be blue 25% of the time. 25% of the time, only the 4th circle will be blue. 25% of the time, only the 5th circle will be blue. And finally, 25% of the time, Blaise will get no more blue circles. So what does this mean? After being treated after time point 3 with ciproflagyl, Blaise had one potential outcome, which was what he would experience after time points 4 and 5 had passed, given his pre-treatment history and treatment with ciproflagyl after time 3. We can observe only one value of his potential outcome, either free of infection or infected, but we know that his probability of being infection-free was 75%. What if we know about another effective treatment for diverticulitis that may not cause as much C. diff infection? Using counterfactual thinking, we can ask the hypothetical question, instead of getting the standard treatment with ciproflagyl, what if instead we had treated Blaise with amoxiclav? This treatment alternative is an intervention, and it opens up this second potential outcome for Blaise to experience, which is what he would experience after time points 4 and 5, given his pre-treatment history and treatment with amoxiclav. We reconduct the example with new information about amoxiclav instead of ciproflagyl. Under our assumptions about amoxiclav, at each time point 4 and 5, there's now a 75% chance of Blaise getting a blue circle instead of 50% like for ciproflagyl. Just like before, we will assess Blaise's potential outcome for after time point 5. He'll either be infection-free or not. After time point 3, the clinician opts for amoxiclav this time. You don't have to worry about the math behind this one, but we'll go through what happens. 56% of the time, both circles will be blue. 19% of the time, only the 4th circle will be blue. 19% of the time, only the 5th circle will be blue. And finally, in 6% of scenarios, neither of those last 2 circles will be blue. To summarize, after being treated at time point 3 with amoxiclav, Blaise had this second potential outcome. Under treatment with amoxiclav, Blaise would emerge infection-free in 94% of scenarios. So we want to understand the causal effect of having amoxiclav instead of ciproflagyl on the development of C. diff infection. Under treatment with ciproflagyl, his risk of infection was 25%. Under intervention with amoxiclav, it was only 6%. Remember that in the real factual world, we only get to observe one story for Blaise. He'll either receive ciproflagyl or amoxiclav, and he'll either develop C. diff infection or not. Imagine that the one story we observed for Blaise was this. He was treated with amoxiclav and he was infection-free. The natural causal question to ask yourself about his experience is, did the intervention to treat him with amoxiclav make a difference? We'll never know the answer to that question. We tend to make judgments about whether or not we think something might have caused an outcome in an individual, but it's very tenuous. Someone could reasonably assume, based on all the data that we saw, that even if Blaise had been treated with ciproflagyl, he would have been free of infection, and we can't disprove that. If that assumption is true, that he'd be infection-free under both treatments, then we would conclude that the individual level causal effect was 0. No matter what medication that Blaise received, he wouldn't have gotten C. diff. So what is the point of all this? Remember when we were talking about counterfactuals early on, we admitted that we can't do time travel. Instead, we can try to find a substitute population to understand what might happen to the average person. This causal thinking approach is important in the clinical setting because our decisions might not always cause better outcomes for a given patient, but over time and with enough patients, a beneficial average causal effect can make a positive outcome more common. How do we assess an average causal effect with a substitute population? Let's find people to stand in for Blaise, small French men in the 1600s with disproportionately large noses. You did a great job and have now identified 760 people that met that description. You run an intervention study on them based on the blue circle probabilities for each treatment, 50% for ciproflagyl, 75% for amoxiclav. The average causal effect is represented by subtracting 7% from 26% and shows that the risk of C. diff infection was 19% worse in patients just like Blaise who got ciproflagyl instead of amoxiclav. If we can intervene on a patient with a different exposure, we can offer them a hopefully better potential outcome. Although we can never know an individual level causal effect, we can use substitute populations guided by the 3 rules of causal inference to guide our attempted estimation of average causal effects. Now we've finished the second chunk. This might be another good time for you to pause. In this section, we'll discuss 2 complementary ideas that can be used for assessing the evidence of causal associations. In the middle of the 20th century, once many infectious diseases had been controlled through sanitation, nutrition, medication, and vaccination, there was a gradual shift toward research into chronic diseases, which are more challenging to study from a causal perspective. In response to this challenge, Sir Austin Bradford Hill developed guidances that he thought could be useful based on his research into the effects of cigarettes on diseases. Hill appreciated the nuances behind this issue and never meant for this to be a checklist. We teach them to you here because they're handy, and you will hear about them in your future, but not because we sanction using them as a checklist. Some of these criteria are more robust than others. I'll present them in the order that he does in his famous speech to the Royal Society. First is the strength of association, which suggests that stronger associations are more plausible, because a strong association cannot be explained so easily by confounding or another bias. There are some problems with this one. First, some biases are enormous. Second, not all causal associations are strong. You can think of air pollution and respiratory health. Third, some strong associations are imprecise and easy to overinterpret. The second one is consistency. This is the idea that associations found in one population would likely appear in other studies of other populations. Many people refer to this to systematic reviews and meta-analyses to guide their interpretation of potential causal associations. If the association is truly causal, then maybe it would have appeared in many other settings. Third is specificity, which is probably the weakest of the 9. It requires that a causal factor is more plausible if it leads to one type of disease, for example, a cancer cluster near a nuclear facility. Cigarette smoking would not satisfy this criterion because it's associated with many adverse health outcomes. From the least robust to the most robust criterion, temporality is essential. This simply states that the exposure precedes the outcome by a period of time that's consistent with the biological mechanism. Fifth is biologic gradient, which we usually refer to as a dose response. It states that an exposure increases in intensity, and that increasing intensity may lead to increasing occurrence of the outcome. The plausibility criterion implies that causal interpretation is supported by a biological mechanism that is known or suspected. In other words, there's some solid rationale for why this association might be causal. Seventh is coherence, which is a little bit redundant with plausibility. Essentially, it states that the causal interpretation does not conflict with well-established knowledge. The problem with this is that if the information generated by a study of a causal association is true, but flies in the face of erroneous knowledge of the day, the study would be discredited. Eighth is experimental evidence, which is often very useful for identifying causal effects. If we carry out an experiment where we alter people's exposure to a factor of interest without altering other characteristics about those people, then differences in outcome occurrence may well be caused by the change in exposure. A limitation to this idea is that experimentation is not always possible, and it's not always ethical. Finally, analogy states that the proposed causal relationship is similar to what might have been seen in other similar contexts. This goes along with consistency, plausibility, and coherence criteria. It also implies that alternative explanations have been considered for what was observed in a given study. Before I jump to conclusions about picking number 7 for my soccer team, I realized that it's more important to be good at soccer and play an offensive position than what number I wear. Just to reiterate, Hill's criteria are not a checklist. In his presentation to the Royal Society, Hill himself said that these should not be used as a checklist, but they can help us think. It's more important to think critically about apples-to-apples comparisons and alternative explanations before jumping to causal conclusions. Now we're going to transition to the second useful tool for considering causal assumptions, directed acyclic graphs, or DAGs. On the left-hand side of the screen, you can see a general framework for predictive modeling, which is often very important in health research. When we're studying an outcome and we want to make it more or less common, it's really important for us to understand about factors that are associated with that outcome, causally or not. Once we know about those factors, like variables x1 through x5, we can identify some of them as the kinds of people or the kinds of conditions that correlate with the outcome. The more knowledge we have about these factors, the clearer our thinking about possible causal mechanisms becomes. Say a factor x2 appears to be correlated with an outcome, and it is something that can be intervened on. Then we might conduct a study to assess its potential causal effect on outcome occurrence. We focus our question specifically on the causal association of primary interest, which is indicated by the arrow in this diagram from exposure to outcome. We tend to observe settings where lots of factors are acting in a network, with probabilistic associations all over the place. We never really get to just look at a clean DAG with just one arrow from exposure to outcome. There are other factors involved. We represent them in the DAG as covariates Z1, Z2, and Z3. They represent variables that cause exposure and outcome. If we don't account for them appropriately, then they will distort our understanding of the primary association that we care about quantifying. In our diverticulitis example, these nuisance factors might be things like concomitant medications, use of health care services, and comorbidities. These factors inform a clinician's prescribing decisions and have implications for patients' underlying risk of developing C. diff infection. This type of diagram can help us formalize many of our assumptions. They allow us to design our studies, collect data, and carry out analysis in ways that can mitigate the noise so that we can estimate that key association between exposure and outcome. You'll see more about DAGs later today and in class. Now that we've concluded this section on causality, this might be another good time for you to pause the video before we get into discussing bias. Here we'll describe the 3 big types of bias. Later in the course, we'll get into details of how to identify these biases and how they can be mitigated in studies. Before we get into any details about bias in epidemiologic studies, let's talk about what bias is in general. Bias is a systematic error that makes someone interpret information inaccurately. In health research, a study's bias depends on how well the study question and the study design align. It is really important to note that bias does not depend on sample size. Some general considerations for thinking about bias. Always anchor your thinking about potential bias to the target population of interest. Once you have that target population specified, make sure that the research question pertains to that target population. It's also really important to clarify what bias is not. Do not get tricked into mischaracterizing random error as a type of bias. After all, it is random error, not systematic error. Random error is typically inversely associated with sample size. And when a study has low random error, it's referred to as precise. To hammer home the ideas that bias and random error are distinct from each other, let's visualize it. To understand these images, let's set a couple of rules. The bullseye is the truth. The farther from the bullseye, the less accurate a result. And second, each set of 5 darts represents 5 similarly designed and similarly sized studies of the same topic. The first image shows a low degree of bias. Everything's right near the bullseye, and they're all really close to each other. The second one shows a low degree of bias again. Everything's averaging near the bullseye, but there's higher random error because the darts are spaced farther apart. This one shows high bias and low random error. They're all together, but they're far away from the truth. And this one shows both high bias and high random error. One of them got lucky, but most of them are averaging toward a wrong answer, and they're not close to each other. Now we'll talk about the big three types of bias. First up is confounding. Confounding is a mixing of effects brought on by a covariate that impacts the occurrence of exposure and occurrence of the outcome. When exposure and outcome share a common cause, the apparent association between exposure and outcome might be driven, at least in part, by that underlying mechanism. Soccer position makes jersey number look more important for goal scoring, and severity of diverticulitis may make recipients of a more aggressive medication have more common side effects, like C. diff infection. How can you identify covariates that might be confounding? The starting point is to draw out your assumptions in a DAG. When considering the relation between two variables, temporality always helps clarify directionality. The rest of these are based on knowledge, either through published research, clinical expertise, or identifying plausible or common sense justifications. In class, we'll get to work with examples so that you can practice building DAGs and understand how to make decisions about the potential for confounding bias in a study. So how can you mitigate confounding bias? Once you have your DAG drawn, you might be able to leverage it in your study design or data analysis. Simply put, we can use design and analytic techniques to control, denoted by having those little boxes around the confounding covariates, or hold constant these nuisance factors so that we can isolate the association of primary interest between exposure and outcome. Again, you'll get more practice with this concept in class. The second main bias is selection bias. There are two main ways that selection bias can manifest. The first is through in-selection, where the sample of individuals that is studied does not represent the target population of interest. If the target population is specified and the study sample excludes certain groups, then the study may no longer be relevant to the target population. If selection differs across groups of people in the population, then there's potential for bias. If those differences are measured, then the study design and analysis can be tweaked to correct for those differences in selection so that there's no selection bias. On the right-hand side, we use our diverticulitis example to propose two ways that in-selection bias could occur. First, if our target population is Medicare beneficiaries getting treated for diverticulitis with antibiotics, and we only recruit Medicare beneficiaries being cared for at UNC Health, we should no longer make inference to Medicare in general. Second, if we're interested in the effect of ciproflagyl versus amoxiclav on risk of C. diff infection, we better start follow-up when the patient gets treated rather than maybe when they first get diagnosed. This is because we want to study the treatment decision that the clinician can make. The second way that selection bias can manifest is on the other end of follow-up. This is called out-selection bias. You can ask yourself, did anyone get lost to follow-up in this study? And if so, did it happen more frequently for any certain groups in my target population? Similar to in-selection bias, this can be addressed if the differences between groups are measured and accounted for in the study design and analysis. Using our diverticulitis example, we might disproportionately lose follow-up on certain groups of people who disenroll from traditional Medicare in favor of Medicare Advantage coverage. This has a lot of geographic differences across the country. In our Medicare database, some people's data will be truncated because of the state that they live in and the norms in that state, but not because of any real reasons related to antibiotic use and C. diff infection. One common misconception is that selection of a study population implies selection bias. Do not fall for this. Just because a study cannot be generalized to other populations does not mean that it was not valid for the target population that it set out to study. Sometimes arguments are made that a study is not interpretable because many different subgroups make up a study population, or that different subgroups experience different treatment effects. But if the heterogeneity of the population or of the treatment effects in that population are true, and if the study was carried out in an internally valid manner, no confounding or measurement error, then it's an internally valid study. It might just not generalize to the population you wished it generalized to, which is too bad, but not anybody's fault. When you're reading studies, always be aware of the temptation to extrapolate inappropriately or overinterpret results. This could be tempting for you as a reader who's trying to find a solution to a clinical problem, or it might have been tempting to an author of a study to gain more traction and attention for their findings. The last major type of bias is measurement error. Measurement error has a lot of different names, but it can be thought of quite simply as exactly what it sounds like. If any variable is mismeasured, whether it's the exposure, the outcome, or a covariate, it can threaten valid interpretation of data. Even though it's simple to name measurement error, it's really unpredictable and complex to interpret its impact. Avoid making generalizations about the direction or magnitude of bias due to measurement error. You might hear people refer to non-differential measurement error, meaning that measurement error occurred similarly in many groups of people, and that might lead to so-called bias toward the null. This is an all too common oversimplification that requires tons of additional assumptions that usually don't check out. Authors should conduct sensitivity analyses to assess robustness of their findings to measurement error. Some common sources of measurement error are shown here. First is detection bias, where some patients get followed up more closely or have more tests than others, which leads them to having higher apparent occurrence of an event. Second and third are reporting and recall bias, which are generally characterized by people reporting exposures for characteristics about themselves, knowing that they have a disease or out of concern that they might be stigmatized for what they did or what their response might be. Now that we've talked about bias and those big three, we're going to explore clear ways to communicate directionality of bias. Later in the sequence of study design unit, we'll get into details around measures of association. For now, what you need to know is that there are two scales for measuring associations, the ratio scale and the difference scale. On the ratio scale, the null value is 1 because the outcome occurrence in one group is divided by the outcome occurrence in the other group. If they're the same, then there's a null association and the quotient is 1. This slide shows the same concepts, but on the difference scale. Here, the null value for a difference measure is 0 because the outcome occurrence in one group is subtracted from the outcome occurrence in another group. So like I said, there are two key questions to answer when interpreting direction of bias. First, is it upward or downward? Second, is it toward, away from, or through the null? This figure provides examples for whichever scale you're interested in. First, we show the null down the middle. In the top example, we show that the true value of the association is indicated by the green dot. The observed value is biased and was higher than the true value. We can characterize this bias as being both upward and away from the null. This schematic diagram lays out all the combinations for potential directions of bias. This will be a good series for you to review on your own and practice getting these descriptors right. We'll end today's lecture with an eye toward where we are headed in the next couple of sessions. One of our main mandates in teaching this course is not only to share scientific information with you, but to train you for that culture that you're going to be practicing in one day. In that culture, there is a pervasive belief that some studies are better than others simply because of the type of study design they fit into. As we've talked about, epidemiologic studies often compare two or more exposure groups using experiment or observation. We'll get into all these different types of studies in the next couple of weeks. This may be the first time you've seen a pyramid like this. It implies that higher quality information is provided by systematic reviews and meta-analysis, followed by randomized control trials, followed by observational studies like cohort studies, and that qualitative studies and case reports are at the bottom. It's important for you to know that this hierarchy exists in many of your colleagues' minds so that you can know where they're coming from when they make arguments in favor or opposed to a potential clinical decision that you're working on together. But it's also important for you to know that there's much more fluidity in the quality of evidence that can be generated across the range of study designs than some simple pyramid. In the coming weeks, this will become more clear as we inspect the relative benefits and trade-offs for interpreting data from randomized trials and observational studies. I hope that this lecture has given you a helpful introduction to counterfactuals and the potential outcomes framework, ways for thinking logically through causal interpretations, and a sense of the main sources of bias in health research. Looking forward to seeing you all in class.